Hi everyone, my name is Giorgio Malaguti and I'm the product specialist for dermatologic and aesthetic laser from Quanta System. I'm happy to welcome you to today's webinar, How to Treat Vaginal Atrophy with Mixer Technology with Dr. Salinas. During today's webinar, you will have the opportunity to submit test question to Dr. Salinas by typing it in the question pane of the control pane. We will collect these and answer during the Q&A session at the end of Dr. Salinas' presentation. Dr. Salinas is a senior gynecologist at the San Juan Hospital. He is also professor of aesthetic and functional gynecology at the Rovira and Virgili University and professor of cosmetic female genital surgery at the University of Barcelona. I'm really glad to introduce you, Dr. Salinas.
Thank you very much, Giorgio, for the presentation, and welcome all to this webinar organized by Quanta. This webinar is going to be about the SheLase hybrid laser, CO2 and 1540, in gynecology. As you may think, obviously we are not able to do a presentation, 40-minute presentation in all the pathologies where the laser can be used, but we will focus on genitourinary syndrome of the menopause, formerly called vulvovaginal atrophy. Well, in this talk, I will try to stress why nowadays it's important to treat a GCM in our patients. Second, what's the role of laser in GCM nowadays? And at the end, I will try to explain why SheLase, the hybrid laser, is probably the best option for treating these kind of patients. So this is me before the lockdown. I look quite different now. And this is the hospital where I work. And where now presently I'm working in a study precisely with this laser and GCM. Well, the first thing that came to my mind when I had this machine is, okay, so what can I do with this laser? As a gynecologist, we don't normally train in laser, but obviously, unfortunately, the team from Quanta is very useful and very helpful, and they will take you through the whole settings and how to make the best of this machine. Laser can be used in many things, and if you have attended the different webinars that Quanta has organized, you will realize that you can use it in aesthetic, in dermatology, and in surgery. But in gynecology, you can use it in the vaginal relaxation syndrome after having delivery babies. You can use it in lichen sclerosis and urinary incontinence, and what we're talking today about is in GCM. Well, what is clear is that nowadays is not like 150 years ago. So 150 years ago, women didn't used to live so long as today. I mean, we could say that women live even longer in the menopause time than in the premenopause. And as you can see, and one can realize, women are not just happy to go through the former type of menopause. Women want to feel fit and well, they want to feel pretty, and also they want a healthy external genitalia to keep enjoying their life, the sexual life. And we know the different types of treatments so far have been more or less fine, but doesn't work in everybody. So what do we have when we have these kind of patients in the clinic? What do I advise? Well, okay, we can give some general advices, we can give some moisturizers, we can give lubricants to have sexual relations, and obviously the gold standard so far that has been estrogen cream. But the laser came in. That was first time in 2011. That was a Adrian Gaspar in Argentina when he started using the laser in this kind of patient. And afterwards, in 2014, in Italy, they started all this bunch of evidence about the laser. But the FDA didn't quite agree with that. And obviously, they still keep saying that we need more evidence in terms of safety and efficacy to use the laser in gynecology. And well, the evidence is coming. Every year, more and more papers are published, and you just have to write down in PubMed laser and GCM, and almost 160 papers come out. And this happens every single year. So as you can see here, the progression of papers have been increasing. So the interest is bigger, and the reason why, it's very obvious. We know what's happening when somebody gets in the menopause. I mean, the lack of estrogen will lead to a series of symptoms like hot flashes, night sweats. Probably these are the ones that most annoy the women, and precisely these symptoms are the ones that tend to go away as the time goes by. But there are others like feeling depression, joint pain, tendency to forget things, loss of libido, etc. But there are others like dyspareunia, because the estrogens, the lack of estrogens, makes to lose the vaginal folds, creates dryness, and obviously that leads to dyspareunia. Also the drop in estrogens will produce an increased destruction of collagen, a change in collagen having more type 1 than 3, and also a decrease in production of collagen. Therefore, the patients are more prone to suffer from de novo urinary stress incontinence or exacerbation of the previous urinary incontinence, but also genital prolapse. But nowadays, as you know, the microbiota is getting more important, and we know that the drop in the estrogen levels changes for sure the vaginal microbiota, making the patients more prone to suffer from urinary infections. So what happens? I mean, there is not just the menopause what can emulate the symptoms of GCM. We know there are other conditions like breast cancer survivors who had chemotherapy in their treatments that can suffer from GCM symptoms. Also, gynec cancers who had radiotherapy, or for whatever reasons, despite that we are more conservative in that term, but some patients already had bilateral oophorectomy, and even in physiological conditions might simulate GCM, like breastfeeding patients. So what happens? What happens with the lack of estrogen is that the vaginal epithelial thins, and there is also a decreased exfoliation of the vaginal epithelium. This exfoliation is the reason why the glycogen production of these cells decreases as well. And this glycogen is the nutrient of these microorganisms called lactobacilli. If this nourishment doesn't go to lactobacilli, there is a drop in the number of these bacteria, and therefore a decrease in lactic acid. And obviously, this leads to increased vaginal pH, typically from these menopausal women. This vaginal pH increase makes an overgrowth of bacteria, and that makes more prone to women to suffer from urinary infections. But there are other problems associated with hyperestrogenism, and this is a decreased vaginal fold, decreased elasticity of the tissue, and decreased secretion by the Bartholin glands, and this leads invariably to dyspareunia. How to look at it? How can we from the cytological point of view see what's happening with the GCM? Well, there is a test called a vaginal maturation index. You see that this vagina is like a rigid tube that the patient might suffer from problems. And when I say problems, I mean that 50% of women will suffer from these problems. And this happens after 4 or 5 years entering the menopause. And unfortunately for them, GCM is a chronic and progressive disease. This changes the quality of life of our patients for sure. And some of them, unfortunately, will have marital problems because, as you see here, a percentage of them will have an stop in their sexual relations, and the ones who keep having sexual intercourse, obviously, they will have a better, much worse satisfying experience than before. So, having explained more or less why is important to know about the GCM, then we'll start doing a little look at what the Shelace can do for these patients. But for doing so, what I'll do is explain you a few studies that came recently, and I think that are important. First of all, we know that the gold standard so far to treat the patients with GCM is vaginal estrogen. So there is a study now recently published in Menopause in 2020. So as you can see here, is a multi-center randomized trial comparing the use of vaginal estrogens against laser, CO2 laser. And what we see here is that in both arms, the patients are very satisfied, so around 80% in all these 3 items: GCM, urinary symptoms, and sexual function. So what this makes a very good option, laser is a very good option for treating these kind of patients. Patients were very satisfied, and the procedure was safe because there were no serious adverse effects. But there is something that the estrogen cream doesn't touch, and it doesn't touch the connective tissue where the laser goes. The connective tissue of the vagina is composed of fibroblasts and smooth muscle cells surrounded by an extracellular matrix. We know that the fibroblasts are the main cells responsible of the synthesis and secretion of collagen and elastin. And we know that the collagen and elastin, as I said before, are important in the mechanical properties of the vagina. But not only that, all this extracellular matrix that is surrounding all the tissue has its importance, as these are constantly remodeling. So far we know that the laser is capable of create new collagen, create new elastin and new vascularization, and therefore is capable of reducing the epithelial degeneration and atrophy, and increases fibroblasts, and increases also the thickness of the epithelium, published in the literature around about 60% of the previous thickness. So, how quick all these early regenerative modifications in the tissue happens? This has been published in 1918. We knew from previous studies that even 1 month and after 2 months of having laser, the epithelium thickens with maturation of the epithelial cells, and also an increased desquamation. And as I said before, this desquamation is absolutely important to nourish the microbiota. It is also, as a second thing, a new formation of papillae. Papillae are important because they increase a better diffusion of nutrients to the stratified epithelium, and transfers these nutrients mainly to the superficial layers and also to the intermediate layers, thanks to these newly formed vessels, all these stimulated by the energy of the laser. And also, there is a new formation of collagen and new morphological features of fibroblasts and so on. And here you can see that all these in this study could demonstrate that happens as soon as 1 hour before firing the laser into the tissue. But nowadays, as a third thing, I think it's important, is that we cannot talk about vaginal health without mentioning the microbiota. There is, in the last few years, there is a growing body of evidence that have suggested that the vaginal health depends on the several factors. And one of them is the local immunity, but also the microbiota that modulates all these local immunity. So here we know that in premenopausal women, the microbiota is absolutely different. There are more lactobacilli. And as you can see, when patient gets into menopause, the flora changes exactly to the pre-puberty flora. And as you can see, if we give estrogens, these tend to turn the flora back again. So it is important. And in the postmenopausal women, as I said before, the pH changes, but not only the pH. As you can see here, the lactate decreases, but there is also an increase in pro-inflammatory cytokines like interleukin 1 and 8. Well, this study also done in Greece could demonstrate that after the laser, the lactobacilli increases from 30% at the baseline to almost 80%, and this also led to a decrease in the pH by 80% of patients. So as we can see, the laser has also an impact on the microbiota and on the vaginal health. But how many sessions do we give to our patients? So traditionally we are giving 3, but can we give 4 or 5? This is an interesting paper. As you can see, looking at different items, dyspareunia, dryness, normal sexual function, BMB, and also the vaginal health index questionnaire. And as you can see, all of them improved, and curiously, they improve more with more sessions the patients had. So that is very interesting. And as we can say, in this study, even the desire arousal and orgasm increased by the 4th session. What is interesting, knowing that this probably doesn't have anything to do with the conditions of the vagina, but rather is secondary to a better function of the vagina. So the patients feel better, and therefore the patients, if they don't feel pain, they might feel better, in a better condition to have a healthy sexual life. But after the 5th session, there is more lubrication and decreases the pain. So it seems that it's safe to give even 5 sessions without any problem and with a better results. And what about the dosage? This is the first study also published recently by the French in the French population. French doctors don't tend to use too much laser, and this is the first study on CO2 laser. They dropped the lower energy to 18 watts, and they have a very good results. I might just remind you that we use only 5 watts of CO2 in Chiles, and that's because we heat the tissue with a 1540, that's a coagulative laser and wavelength, and we just have to drop dramatically the energy of the CO2. There is another group of patients that needs to needs attention, and these are the breast cancer survivors. As you know, 70% of these patients will develop GCM symptoms because of the change in the vaginal microbiome, and we know that the lubricants, moisturizers, might help, but might not help enough. In some patients, we can give estrogen cream, but in others with aromatase inhibitors, it's not allowed to give any kind of estrogen cream. And that puts the patient in a very difficult situation, because intercourse can be very painful. The vagina, after using chemotherapy and all these medication that we are anti-estrogen medication, makes the vagina very sensitive for pain, and we don't have much to do for these patients. So the laser has been used in these patients, fortunately with very good results. They laser improved the vaginal dryness, also the dyspareunia, the itching, dysuria, and improves the sexual life. And that's very good news for these patients. So it's safely and convenient to use this technology in these patients. I think we can say it without any problem nowadays. And now there is another very recently published paper in the Climateric, very interesting, because the ones that we treat with cancer patients, we see these quite often, and this is gynecological cancer survivors who had brachytherapy, and as you can see, brachytherapy could lead to very bad side effects. As you can see here in the grade 1, there's nothing much, but if you see the grade 3, it's absolutely tremendous. These patients are not, it is very difficult to have sex with these vaginas. Some of them are shorter, they bleed quite easily, they are like a rigid pipe. It's difficult to improve this problem. Well, this paper published recently, as I said before, has demonstrated that the dyspareunia, superficial and also deep dyspareunia improves. Also improves the dryness, the stenosis, the postcoital bleeding, and even the radiation cystitis. So there is hope for these patients. We need to keep studying on this, because we have lots of patients with these conditions, with very difficult sexual life, and there is nothing that we can do at present time but using estrogen cream and dilators. Another kind of problem, and is also that falls into the GCM syndrome, is the vulvar vestibulitis. In the vestibule of the vagina, there is a high concentration of estrogens and testosterone receptors. And with the lack of estrogens and also the testosterone that starts dropping very, very quick at the age of 35, the levels of testosterone start dropping down. And all this drop in hormones makes the thinning of the epithelium and exposes a dense bunch of sensory nerves to the nausea of the friction of having sexual intercourse, and this obviously leads to very painful intercourse at the level of the vestibule. Well, this study showed that the pain and also the dyspareunia improved after the laser treatment in around about 70% of patients. So here we have another good tool to use in these patients who are, in other words, difficult to treat as well. Regarding the urinary incontinence, I just want to mention that in 1990 was Petros who mentioned the importance of the connective tissue and the vaginal laxity in the stress urinary incontinence and also the urgency of voiding. So we could say today, I mean, there are many reasons for suffering from urinary incontinence, but for sure nowadays we know that the weakness in the fascia and also the ligaments that are composed by collagen and elastin are important to keep the continence under control. But not only the fascia, but we know also that there is a sphincter in the urethra that is the function of these sphincter is to maintain, to keep patient continent while having a normal life. And to do its work, it's absolutely necessary to have a good amount of collagen and elastin, and not only that, but also a very good vascularization and innervation. And in that sense, it seems that the laser can work as well because all the properties that we mentioned before. We know that the laser can create collagen and elastin. We know that where we fire the laser, the vascularization will come again, and these might help with the urinary incontinence. Papers, all of that with CO2 laser, just a couple of them, but in this couple of papers, all these items have improved. So the urinary frequency, the urge incontinence episode, but the urge of going to the loo as well as all the quality of life and overactive bladder questionnaires improved. It is true that we need more papers and more studies on this to get the right power, the right settings. But we can say that we are working hard with that, and we are in the good direction to treat patients with urinary incontinence, thinking that obviously the ones with very severe incontinence will need surgery, but we are talking about the patients who might need conservative treatments. And we know that so far the conservative treatments are in hands of physiotherapists by doing the pelvic floor rehabilitation and electrostimulation. The problem with that is, unfortunately, these patients may benefit initially, but as the literature says, most of the patients finally gets bored of doing the exercises every day, and eventually the patients drop out of the physiotherapy scheme. And finally, another important issue nowadays is the fact that if we add different type of medications or we combine treatments, we might have better results in different pathologies. This is a paper published also now in this year using the PRP, the platelet-rich plasma, with CO2 laser in stress incontinence. And as you can see here, all the parameters improved. And what is more important is that the incontinence improved even after 12 and 14 months. So this is the way that I think we should go. I think the studies are to do the studies as we are doing in the hospital. We are just using our laser in GCM, but I think in the private practice, I would probably go for the laser and combining with other kind of treatments like plasma-rich platelets. As we know, there are lots of different growth factors that improves the tissue where we inject the plasma. So why now? I'm just gonna trying to explain why I think this the hybrid laser is the best option. And as you can see here in this graph that probably you have seen before, we know that the CO2 laser is very fond of water, but even the heavier jack is more prone to be absorbed by the water. So that means that when we fire the lasers, these lasers, most of the energy is going to be absorbed by water, and therefore the penetration, the heat penetration into the tissue, that is one where we want to go to the connective tissue, is going to be lower than if we compare it to the 1540. As you can see here, the 1540 is less avid than for water than the other two wavelengths, and that is the beauty of this 1540, is that is a correlative wavelength that you can go further inside the tissue to hit the connective tissue and to remodeling all the extracellular matrix in a properly more efficient way. And it's not that it's more efficient and effective than the other two, because it can penetrate straight away, but also the fact that we can decrease the power of the CO2 makes less bloody the procedure. And if we decreases the bleeding of the procedure, we reduce the risk of infection, and probably we decrease also the risk of very unlikely long side effects. I think it has been demonstrated from previous biopsies on the dermis, not on the vagina, but on the dermis, the enhanced collagen formation with the 1540. You can see here what's happening. What is happening in with these 1540 and the CO2 laser. So there is a little ablation with the CO2 that is even lower in our case, because, as I said, the power is much less than used in studies where only a single wavelength, and the 1540 penetrates even deeper in, releasing the heat deeper in, probably almost getting into the lamina propria of the tissue, stimulating what we want, the target. Here's what here you have what happens when the CO2 fires. It's fired. You can see that the heat doesn't go too far from the lesion, and it's completely different in the case of when we add the 1540. As you can see here, is the heat is widespread all over the tissue around the lesion. And that's it. And that it is very important, because at the end is what we want, is what we need. We used so far 3 sessions, and we know that we go 1.2 millimeters inside. You must bear in mind that with a CO2 laser, and even is much less, and even lesser in the case of the Erbium jack, because they are very ablative lasers. All these are used with this handset. It's a very comfortable tool to use. It's very easy. As you can see in the screen, it's very intuitive. We can change all the parameters without any problems. We can have all the information on the right side, the power that we are delivering, and everything. We use 2 speculums. Normally, I use the 9 centimeter speculum, and as you can see here, the vaginal probe can be used today without the speculum. And now I'm using it in the study because the patients that I'm treating are having very atrophic vaginas, and obviously I'm not able to put in a speculum inside. It is very it's very easy to go in. Yeah, it could be a bit more difficult in very atrophic vaginas. But,
Sorry, John.
yeah.
Sorry to interrupt you. Maybe you covered the microphone because it's lowered the volume just for the last 20 seconds.
Okay. Can you hear
now
me?
It's better. Now it's better. Yeah, great.
So sorry about that. What I was saying is that these that the probe is very easy to use to insert into the vagina, even in atrophic vaginas. There are some tricks that could show you sometime to go in without damaging the patient. I think one of the beauty of this laser is that it's a 360 full vaginal coverage. That means that we finish the whole procedure in 2 quick passes, and that makes a lot of difference in lasers with only 45 or 60 degrees coverage, because you need to go in and out more times, and as you go in, the vagina gets inflamed, gets more difficult and more uncomfortable. And as I can assure you that when doing it with this laser, this doesn't happen, because there is no time for the vagina to get inflamed. So it's a very tolerable procedure without anesthesia. And also it's very easy to see where you are. So you can get orientated by this device here, where you can see exactly if you are doing half a centimeter away in every single shot. It's very easy to use, it's very intuitive, and you won't forget any single centimeter of the vagina. Another interesting point of this laser is that you can use almost all the settings in the handset. And nowadays it is very important with the COVID thing. As you can see here on the screen, we are using, now it's used 120 means 120 millimeters. So we are using the speculum of 12 centimeters. We can 120 means the number of spots. We can look at the coverage. Here is a 360, but you can use it as a 180. You can use it on the top of the vagina, only on the bottom of the vagina, on the left-hand side, on the right-hand side. You can use it as you want, and this is absolutely very comfortable without having to turn the device. And at the end, we use this vulvar kit for the vulva. Obviously, when you use it with the vulva, we need some kind of anesthetic. And I will show you, just to finish, how is this laser and how is the procedure performed. The vaginal probe is very easy to set into this kind of gown. We change the optic for the vulval kit. I think this is very ergonomic. And what is most important is that you have all the controls in your hand setting.
So there is no need to touch the screen. Tool size, normally we use the 9. These little devices help us to know where we are, and the laser can be fired as you prefer. You can use the first the CO2, the 1540 after, or on the other way around, or both together. So you can fiddle around as much as you want. And this is one of the most amazing things, is the 360 degrees coverage of the vagina. You just need 2 passes to cover the whole 360 degrees. And it takes less than 10 minutes to do everything. And when I said 10 minutes, I said to put the probe inside and do the whole procedure. So I think probably to put the probe inside in a very atrophic vagina might be the most challenging thing, but it's absolutely fantastic. So when doing the vaginal treatment, first thing that you have to do is dry as much as possible the vagina, because as I said, the CO2 laser is very fond of water, but despite the 1540 is less a habit of water, still is. So my advice is to dry as much as possible. So what I do is I use a vaginal speculum, and I dry the vagina with a swab, and then I put the laser speculum and the device. As I said before, when the vagina is very atrophic, I don't use the speculum. And this is what happens when you are doing the laser. So okay, the blue one is the 1540, so it goes deep into the lamina propria. And the CO2 is much shallow and ablative. We do 2 passes, and we hope this to happen in the future. Then we change for the vulval tip, and with the vulval tip, what I do is focus not only in the labia minora or labia majora for aesthetic reasons. What I do is focus on the vestibule. As I said before, this is the more sensitive part of the vagina. Many women suffer from pain at the level of the vestibule, so is mandatory to do it with this vulvar kit. And also what I do is trying to reinforce the external urethral ligaments with this vulvar kit. It's mandatory to use local anesthetic at this point. Well, this is a study that we are running now in my hospital. Hopefully, in the future, I will be able to give you some data with it. And as in conclusion, I would say that Shieldlaser, for me, might be the best laser choice to treat the GCM for all the things that we've been talking about. Is a good alternative in gynecological and breast cancer patients. Another thing is it probably might be the safest laser, and obviously that decreases the tissue ablation and the risk of infection, and probably will prevent the unlikely long-term sequelae of the laser. Increases the number of sessions. So there is something that we need to keep studying. So so far we are using 3 sessions, but might be better probably in the future using even more times. And there is no doubt that the association of treatments will improve the results of our patients, being the laser the vehicle of for a greater penetration of anything, any active principle that we use, estrogens, hyaluronic acid, PRP. So at the end, in the private practice, probably the best way to treat our patients is a combination of treatments. And I think with the Shieldlaser, we have a very good alternative to treat the GCM. And I think with this, I'm finishing now the talk. So, Giorgio, if you want to go through the questions, please.
Yes, Ivan, thank you so much for the presentation. We have a couple of questions. So right now we move to the Q&A session while we are continuing to collecting other questions. So the first one is, what is the time lapse between each session you provide to the patient?
Well, at least when using a laser, at least we need a month. But we could do it every 4 to 6 weeks without any problem. So we know that initially there is an inflammation that will take 72 hours. Another thing I haven't said is that the inflammation is very low. So I can assure you, because I'm running the study and I know how the patients do, that the patients don't have any side effects with this laser. They don't even have discharge that normally happens with a CO2 or Evian JAK laser. They don't have anything at all. They don't have any side effects. So we know that the collagen start working during all this month. So we are producing collagen along this month. And we know that after the month, the old collagen and the extracellular matrix, it's coming again. So at least a month. So I would say between a month and 6 weeks.
Okay, great. Thank you so much. So going ahead to the next one, is the combination of the 2 wavelengths comfortable for the patient?
It is indeed very, very comfortable. I can tell you that because it's so fast, inside the vagina, as I said before, in a vagina, believe it or not, the 2/3 inside the vagina is not so sensitive as is the third out, the outer third. So inside the vagina, there is no problem whatsoever. And when we come out, right, mainly at the entrance, that could be a bit uncomfortable. But I can say that in my study, I have noticed that you will see in the future that the VAS scale for pain is more or less the same than for those who I'm treating with placebo, because the study that I'm running now is a control one, is a randomized double-blind randomized control trial. So the patients are treated with laser, and this is another group of patients without laser. So we do everything the same, but we are not delivering energy. and in both groups, they have more or less the same pain. So I would say that yes, it is very comfortable.
Great, thank you. So connected to this one, do you use anesthesia before the treatment with Shilase? So probably you answered during the presentation, but maybe it's better to.
Yeah, because in this study, no, I'm not using any anesthesia, but as I said before, I think if you're using in this study that I'm running, I'm not using the vulvar tip because obviously this would mask where the patient is, in what group is. Okay, so it is mandatory to use anesthesia for the vulva, and also to treat the fourchette. There is no need for anesthesia inside the vagina. And I want advice to use the anesthesia because obviously the energy of the laser will diffuse with this anesthesia, despite that you try to dry it out as much as you can. No, there is no need for inside. At the most, only in the labia majora, labia minora, and the fourchette. That's it.
Okay, thank you. So moving to the next one, what are your pre-treatment and post-treatment protocols for Shilase?
Well, to be honest, we are using only 3 days of like a vaginal tablet or novel with somehow reparative aloe vera. But I must say that there is no need for using anything at all, because most of the patients don't use anything, and most of the patients don't complain of anything. So if you want just to be sure that you're not going to have any problem, for 3 days I use this oil with aloe vera, but there is no need whatsoever to use anything at all. I just advise them not to have sex or any intensive sport for the next 3 to 5 days, and that's it. Nothing else.
Okay. Okay, great. Okay. Thank you. So, finish the question. Don't worry.
Sorry.
So, thank you so much to all attendees for your time. Thank you to you, Joan, for your time and for your explanation. I hope that this is really helpful for everyone who attended this webinar. I'd like to remember everyone to stay connected with us following from the Quanta System website the next webinars. And I'd like to thank you, everyone, for your time.
Well, thank you very much, Giorgio, for the invitation. And well, I hope this has been useful for the companions that have been connected so far. Thank you.
Okay, last stuff. I would like to remember to everyone, if you want to see again this webinar, you have to ask the connection link to your Quanta System dealer or representative of your country. Bye-bye. Thank you.
Thank you. Bye-bye.